So thank you all for joining us today. This is our latest installment for the Pharmacy Ethics Speaker Series from the University of Colorado Anschutz Medical Campus. I'm Joshua Semock. I am a fourth-year pharmacy student, and I'll be your moderator for today for this event, From Prohibition to Prescription, Ethical Considerations in Medical Cannabis Use. This event kicks off our theme this year about federally illegal substances and their potentials for therapeutic applications. This program is produced in partnership with the CU Center of Bioethics and Humanities and SCAG School of Pharmacy and Pharmaceutical Sciences. In our other events, we've been aiming to explore ethical considerations and challenges and opportunities in the healthcare industry, especially with relevance to pharmacists, trainees, current students, and prospective ones. So if you enjoyed today's event, please join the Center of Bioethics mailing list or check the campus event listings to get a full detailed list on our upcoming events, which in the spring should include an event about psychedelics. Our topic today is medical cannabis, and we have a fantastic lineup of panelists for you, and I will briefly introduce them. So we have Dr. Robert Page. He is a PharmD, Master of Science in Public Health, and a professor at the school in the Department of Clinical Pharmacy and Physical Medicine. We have Dr. Jacci Bainbridge, PharmD, who is also a professor at the school in the Department of Clinical Pharmacy, as well as Dr. Kelsey Schwander, PharmD, an assistant professor at our school, and as well as the founder of B Health Consulting. Online, we have Dr. Dominic Sisti, PhD, from the University of Pennsylvania. He is an associate professor in medical ethics and health policy, and he also directs his university's program on applied ethics of behavioral healthcare. So let's give them a round warm of applause. Before I go into individual questions to start off the discussion, I'd like to briefly frame the reason that we're here today. So medical cannabis has been an ethical dilemma for our industry, as many states have begun to restore justice by decriminalizing and legalizing cannabis, whose federally illegal status had disproportionately resulted in incarcerations for minority people and those in the working class. These progressive moves have brought back the autonomy of using cannabis for those whose occupations don't prohibit their use, such as many healthcare workers or even school bus drivers like my mom. So, however, adding another socially acceptable recreational substance to the menu, along with caffeine, nicotine, and alcohol, which all have their own associated risks, has brought cannabis into the focus of healthcare workers, specifically on the bioethical concepts of beneficence and non-malfeasance. Bioethics can be interpreted as the philosophy of healthcare, whose core concepts of doing no harm are jeopardized when any substance becomes socially normalized. I think these concepts of recreational use and medical use are very intertwined in our culture, especially around cannabis. However, the purpose of this talk, I would like to narrow to the frame of the medical potentials of cannabis regarding its safety and efficacy, which our panelists have specialized in. I would like to start with Dominic, who is online, Dr. Sisti. You've written at length about ethical considerations for medical cannabis, and so we're very glad that you're here with us today. Could you tell us what drew you into this work?
Thanks. I really appreciate the invitation. Wish I could be out there in person. But I'm here in Philadelphia, and in Pennsylvania, we have medical cannabis. And I was very interested in the ways primary care providers in particular understood and knew about the benefits of cannabis or risks of cannabis, primarily because I myself became a medical card holder and a medical cannabis user when I had serious back pain, and it was the only thing that really worked on the nerve pain. As I like to say, I came for the medical for the medical uses, and I stayed for the Pink Floyd. But the idea was that I actually found the medication to be extraordinarily helpful during a time when I was really desperate. And so and while I was going through that process, I realized my doctors don't know anything about this. I'm learning about this from the internet and from some of my stoner friends, to be honest, about how to use this responsibly and effectively to treat pain. And so it became clear to me that there needs to be some kind of education around medical cannabis, particularly for people who maybe rely on it in particular for pain control, when their doctors don't really have any idea about what to do or say regarding their use of cannabis. So it was pretty apparent that I mean, when I was basically teaching my primary care provider about what I was using and why I was using it, and she was very interested in hearing about it, but it felt like this is not the direction this kind of informed consent should be going in, right? Uh, and so um, and so I wrote a paper with my colleague Aaron Glickman about 5 years ago now that kind of laid out some core competencies we thought that primary care providers should have when it comes to cannabis, and also frankly cannabis use disorder, which I think is a significant risk that is underplayed that we need to probably talk about more. um, I think that providers don't really understand, many providers, maybe it's gotten better, and I'm speaking in terms of Pennsylvania because it could be very different in Colorado. I just don't know. But just the different modalities, the different ways you can actually use cannabis, the different formulations, the fact that there's so much, there's so many different cannabinoids that interact with each other and create different effects for different purposes, needs, or indications. Physicians don't seem to recognize this. They think of cannabis as one like thing, and that's it. Um, the other piece was just the recognition that what I was getting at the dispensary was often inscrutable in terms of what was in it, how much, what the potency was like, what it would do, and the dispensary people had a lot of confidence in telling me what it would do, but it was usually just based on anecdotal evidence or what they had experienced themselves with a certain strain, for example. And so it just felt like a Wild West, and it still feels that way in terms of medical cannabis. And so I think, this is where bioethicists step in and say, well, we need to really shore up how informed consent unfolds when it comes to counseling a patient about medical cannabis use. And that means that clinicians need to have the competency to be able to talk about cannabis in a way that's evidence-based, um, and in a way that's honest about risks. So I think those were the key issues. It was really from personal experience and recognizing that clinicians are still pretty far behind in terms of knowledge about cannabis and its benefits and its risks.
Thank you for that. I feel like you touched on a lot of the themes that I'd like to incorporate in this talk. But before we dive into that, I'd like to continue with our brief introductions here. Dr. Schwander, you've promoted in our lectures that kind of the legalization of cannabis has followed you throughout your journey of becoming a pharmacist. And now you actually act as a consultant pharmacist who specializes in cannabis medicine. Could you tell us more about that?
Yes. So, yeah, I always joke that cannabis follows me wherever I go. I grew up in Colorado. I did my undergrad out in California when it became medical. And then I went back to pharmacy school in Colorado when it became recreational. And then I moved to St. Louis where it became medical. And then I started practicing in Illinois. It became recreational. So literally, I just say if you want it to become legal in your state, invite me there. I'll live there for a couple years and it will follow. So I've really had the advantage of being in multiple different states and just seeing how it's been rolled out. And so I've had the ability to work with patients, work with providers, work with dispensaries, companies that are working with dispensaries, and just giving them advice on what I've seen. And how do we best, for safety and efficacy for our patients, how can we roll this out in a better way and how can I help them? I've been in primary care, I've been in community pharmacy, and now I'm at an intensive outpatient program here. So the Marcus Institute for Brain Health, where we treat mild traumatic brain injury in veterans and first responders. And I have to get them off of cannabis because we have to test their cognition. So again, I've really had the advantage of seeing all sorts of different disease states and people and different just states and how they roll it out. And so that's kind of where I come in, and I have that advantage of having just a new perspective from, different states and how I can, bring my education here.
Thank you for that. And Dr. Bainbridge, you're kind of our resident neurology specialist who's doing clinical trials with cannabis right now. And I've had the pleasure of being on rotation with her and had seen the background of that. So if you could just briefly discuss how your pharmacy career led to involvement with cannabis.
Thank you so much, and I'm happy to talk to you all about that. So my journey, I guess, Dominic, I'd like to echo some of the things that you said, not the fact that I was using cannabis products, at least we can say on a current level. In the back dark ages, maybe, but that was a long time ago. However, I have a shared...
First generation cannabis.
Yeah, doesn't count. Yes. So I can say that I have a shared position in the Department of Neurology. And what we were noticing is that so many of our patients, so we're talking about epilepsy patients, we're talking about multiple sclerosis patients, patients with movement disorders, et cetera, were using cannabinoids to augment their traditional therapies, or even coming off of their traditional therapies, thinking they were more natural and that they would be safer for them. And our clinicians, so that's where I'm echoing what you both have really kind of highlighted, is our practitioners really had no idea really what kind of dose, what interactions that we would see with patients, how to adjust their doses. And so it was all a big, huge question mark and a really void. So that's when I got involved in clinical trials here on this campus. We had the first CDPHE grants that were actually funded to study cannabinoids in back pain and also Parkinson's disease tremor. And autism, behavioral issues, even some of the pivotal trials for Epidiolex. So I thought that was really important, and I really wanted to fill that gap in between and help our providers and our patients use cannabinoids responsibly.
Thank you for that. And lastly, Dr. Page, I've actually been following your interviews you've done on local news stations and nationally, even for CNN or with the American Heart Association, about the risks of medical cannabis. As many of you should know, that he's an expert on cardiology. And so how does that come into this issue?
Awesome. Thanks again for having us here. From our standpoint, Jacci, you've been here 30 years. I've only been 26. So anyway, but you still have hair color. Anyway, and actually, to Dominic, to your point, one of the big issues that has arisen, I think, is what I call poor cannabis health literacy. Again, thanks to our colleague, Dr. Kroll over here, who's also brought some attention to that as well. He is a PhD toxicologist. And the problem that exists is that the data just suck. All right. Everything is going to be observational. And so, but that does not mean you throw the baby out with the bathwater. a lot of what I do, I work in advanced heart failure and heart transplant. And so I've been dealing with this since 2000. And because I am a pharmacist in a deep blue state with cannabis, everyone assumed that I automatically knew everything. So I had to really do the same thing that all of you did. I had to really educate myself. And then when it became recreational, I actually got to meet some of the dispensaries, toured them in order to understand the products. But to get back to that point is that the data are very poor. And I do have to say that it is, anytime you see any data, it's usually from very bad sources like the National Inpatient Sample, which is, bleh. I always reject abstracts that come from there. And you would think that cannabis is going to kill you. I do believe that these are red flags. And there are safety signals, but the magnitude that is reported in the literature is a little bit overestimated. The other thing you have to take into account is making sure that you're open-minded and transparent. I'll be on the national news, and then the next day I'll get a call from someone from California who immediately starts off by saying, "You recommend Western medicine with nasty side effects." And I'm just like, whoa, 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 whoa. No, my job, I said, these are associations, but my job is to make sure that you have the best health care and that your health is a priority. And honestly, I think you need to be able to make an informed decision. And so my job is to present these, but also to be very transparent. And I will not lie to you, that guy was just like, "You are such a," I was like, "Dude, I have to deal with students all dang day. I understand." So anyway, but no, they very much are like, oh. But do I believe, I'm going to jump directly to my question. Unfortunately, we put the cart before the horse. Without ever doing any evaluation, at least before like NSAIDs went OTC, we at least had data with them, but here we don't. And the data are not looking very positively in terms long-term when we think of things like heart attack and stroke, particularly in young, very young adults and who think that they're invincible. And so you have to temper it with that.
Sorry, everyone's just testing out the mics. Test. All right, let me know if you can't hear me online. We're testing out this mic. So thank you all for the introductions there. So I'd like to open up the discussion more generally. So I might frame these questions to one of our speakers, but please feel free to chime in afterwards. I think a lot of you touched to the concepts that I'd like to get to during this discussion. Let's start with the framing that cannabis is a natural and therefore safer product to use. Dr. Page just illustrated that we can't really make those assumptions. And now we're seeing that the risks are truly coming out with that. And also keep in mind that a lot of the medicines that we use are derived from natural products, but synthesized in a way that we know exactly what compound is in there and what is not in there. So I'd like to see a discussion about what's in cannabis. We know that there's THC, CBD, and 1,000 other chemicals, but really what is a patient getting when they're using cannabis?
One of the big problems that I run into from a transplant standpoint, unfortunately, I've been around in transplant long enough to remember when we only did 10 heart transplants, now we do 80. And one of our patients actually did grow aspergillus on his tongue. And so you have to keep that in mind. That's one reason why I'm very happy with the dispensaries. Now, there's no really way to, there in terms of safety and control, but it's better than what's on the gray market, because again, you're going to have pesticides and fungicides that are also extremely toxic. So just because something is natural doesn't always make it safe, even in its preparation. All right.
I totally agree with that. And I think in the neurology world, at least, we have kind of done our homework on who we would recommend or lists of people that we would recommend patients obtain products from. And that's when they can't get medications that's like Epidiolex that's FDA approved. Which that's where I feel the safest. I guess one of my big beliefs is that we should keep it as a medicine so we know exactly what's in it. We know what dose that we can recommend. We know we know exactly what's in the product. So I always try and recommend those products or those places for patients to obtain their product and obviously report if they're having any side effects. Also important to go back to the certificate of analysis if one exists, and that should be available at most of the dispensaries, although I think that has tapered off a bit.
I've
Um,
never seen it.
Um,
Oh,
yeah.
wow.
It used to be that that was the thing. Like we would have to actually have that when we first had dispensaries.
Yeah, they used to have like a QR code.
Yeah.
Sometimes, and it would take you to the certificate of analysis so you could look at it and say, oh, okay, they actually tested the product. This is what's in it. Just to add on to that too, I think the dosing, it varies greatly. I mean, there's been a million studies done that, a 10 milligram THC in this company is actually a 20 milligram in this company. And so, I do a lot of patient education. And so I always tell my patients, stick with one company. And then, when you want to switch companies, stick with another one. Don't go back and forth because the dosing is so different between the companies as well. So again, it just goes back to, what are we giving our patients? What dose? We just don't have the data that we need.
And I also think there are 3 great articles that I can think of. There may be more that I'm missing, but one was a JAMA article that was published, I think, first, and then yes,
Yeah, that's a research letter.
yeah, the variabilities. So either under labeling, over labeling, or right on the mark. And most, I would say most consistently, it was either under or over. There was another article that was published actually by my previous fellow, Owen Miller, and again showed the same inconsistencies with product labeling. And then most recently, Barry Goodell and a handful of other folks looked specifically in Colorado to see, again, the labeling. And again, it was very consistently off.
Yeah, that does seem like a worrying concept that seems like it comes in with a lot of the natural products and even supplements. So one question that I was looking forward to ask is, how can a physician be quote unquote prescribing something that doesn't have a true FDA approval like these natural product cannabis? Like I understand why Epidiolex, which is FDA approved for epilepsy, is FDA approved because there have been rigorous tests about it. But in what context can a physician prescribe cannabis for use?
I can start that. So they're actually not prescribing cannabis. They're certifying a patient for a disease state that is covered under that state where they're allowed to get it. So literally a patient can walk into the office, the provider can just say, okay, you have glaucoma or PTSD or whatever it is, and they don't have to say a word about cannabis and they can walk out the door. Again, because it's federally, a substance one, they can't be prescribing it. So that's kind of the workaround. And unfortunately, that's where we see this huge gap with our providers in education. I mean, so many of my patients, when they come to me, they're like, oh, I got zero education and, very, little education at the dispensary, from the bud tenders who some of them are really well educated and a lot aren't. And so that's where we can, especially as pharmacists, step in and give, dosing recommendations and, how to take in what to expect.
I also think there's a fear around that as well. So a lot of physicians or practitioners are afraid to document that they've had any discussion with patients. Even though I think that's gotten a lot better, wouldn't you say?
I would say yes. I agree. Yeah.
So
Mhm.
so that and I think it's the lack of education, like you were saying, Kelsey, that they really didn't have the education to feel like they could actually counsel a patient or know what to recommend. And there's actually some misconceptions out there about the difference even between THC and CBD. So yes, they both work in the brain, so they're psychoactive, but one produces euphoria and one does not. So there's a lot of misconception out there amongst the community and also the practitioner standpoint. So we do have education. So we in the recent past have had a CE program. We have a master's level program. We have a cannabis elective that we're offering additional information and education to various levels of individuals interested in cannabinoid science.
So my experience, because I'm in the division of cardiology, I'm considered the pot pharmacist. So after we've exhausted all prescription aspects where we have data, they'll say, I think we're going to try this. Now I realize I'm in a heart transplant situation here, which was significant interactions. So just to let you know, I mean, our providers will recommend whatever we only use unit dose, no liquids, no cookies, no brownies. We'll use Ripple, which is one of the powders that theoretically has 10 milligrams in it, and this, that, and the other. Anyway, but patients have to consent, number one, okay? And number two, they also have to agree to stick, just like as Kelsey mentioned, they have to use the same dispensary and the same product, and they have to use it on a regular, scheduled basis. Just kind of like what we used to teach you with how you educate someone with Coumadin. Stick with the same brand, be consistent with your green leafy vegetables. Same thing with this. You have to be consistent. We also will screen them for CUD, cannabis use disorder, by our social worker. And then also they have to take a picture of the product, and also it goes in the medical chart. So there's, again, a lot of steps that go through at this point, but I have them treat it just like a prescription. And that's the respect you should have for it. It's like herbals. Herbals, just because they're natural, does not make them safe. I treat those with respect like a prescription. So.
Yeah, I'd like how you're framing that argument, and I'd like to progress the discussion back to something that Dr. Sisti might be able to chime in on, is that it seems like the legal landscape of cannabis is evolving. We've probably heard in the media that the government is even thinking about rescheduling it from a substance control 1 to a control 3, which basically puts it in the same domain as Tylenol, codeine, but you can't go to your corner market and get Tylenol codeine whenever you want. There are some obvious restrictions. So if you could chime in, Dr. Sisti.
Yeah, I mean, I think, well, just to back up for a second here and just say, yeah, I agree with what the other panelists had said about this idea of natural being safer is a fallacy. We know that anthrax is natural. It's not a great thing. But in terms of the expanding, marketplace, at least in Pennsylvania and in New Jersey, where actually it's there, you don't even need a medical card in New Jersey. It's just kind of open season for cannabis over there. I think it's going to be really important for providers to ramp up their knowledge and get ready to counsel their patients, screen for risk factors like history of psychosis, spectrum disorders, for example. We want to be sure that we're not giving young people who may be at risk for schizophrenia high dose, high potency cannabis. I don't think that's a smart idea. I think physicians need to be really aware of that. I think that advertisers too should be. I mean, I think I see these billboards around Philly for cannabis. I think that there needs to be some regulation around how medical claims are being marketed. So prescriptions, prescription medications, there's a difference here, are regulated by FDA and FTC, and medical claims by FDA around medical claims, and non-prescription or non sort of FDA regulated products should be regulated by FTC, and sort of cannabis falls somewhere in, some liminal space where these growers and dispensaries are making all kinds of medical claims that I think are dubious at best, and dangerous at worst. And so, you know, this evolving legal landscape, I hope, will include not just the expansion of access, but the honing and the tailoring of clear education and messaging for patients and consumers so that they don't, you know, end up using high potency cannabis that triggers a psychotic episode or that takes them down a road of cannabis use disorder. I think those are serious risks, and no one, you know, we don't really see those front and center anywhere, at least in Pennsylvania. So the evolving legal landscape should include, you know, the decriminalization still. There's still people in Philly jail who are there for marijuana-based crimes, and expanded access for the right reasons, and I think regulatory oversight of messaging and communication and advertising.
Yeah, I think you really hit the nail on the head there that cannabis needs to be used for the right reasons. Like, obviously, we have a culture that uses cannabis socially, just like we have alcohol, but there's no true medical use of alcohol. So it's kind of a different beast in that sense. So I think that comes back to the dilemma that I highlighted at the beginning, where, you know, there's the autonomy of the patient. Even if they don't have a true diagnosis which allows them medical use, they can still get cannabis recreationally in many states. And that, on the other side of the scale, is that non-malfeasance, where us healthcare providers are trying to make sure that the patient doesn't get harmed. So would you be able to talk about that dichotomy and where you guys as pharmacists specifically see where you can intervene in that dilemma?
Yeah, so I think, it's kind of a rock and a hard place where, some of my patients, for example, are using it therapeutically, but then are told, oh, you can't, you're not supposed to use it. You can't use it for this disease state. There's not enough evidence. And so I think it really comes down to education, like we've been saying all along. With patients, it's hard for me, like if a PTSD patient who comes here who's using it for nightmare control, which is common for my patient population. And then, we have to tell them to get off of it for other reasons, cognition reasons. But it's really hard to be like, okay, the campus rules here is, we're a THC free campus, but these patients are really using it therapeutically. So I think it goes back to going back to my organization saying, hey, we have cannabis use disorder tools that we can be doing with all of our patients. So we can start recognizing those signs and symptoms of that and when we need to be concerned versus when patients are using it therapeutically. And I think if we're able to articulate that to our team and our providers, I think everyone's more aware, like, okay, that maybe, the evidence isn't there yet, but the patient's being safe. They're using doses that are appropriate and that are mimicked in some of the studies that we do have. They're not having side effects. There's no drug interactions. We do the due diligence just like any other prescription. And then I think, we need to be more accepting of
it. One of the problems, like about, I have my residents. Were you guys with me when we had the hyperemesis? No, that was last month. Alrighty. So what happens is we have patients who are using it either recreationally or medically, and then they come into the hospital with cardiogenic shock, and then they get sedated, and then they go through withdrawal. And I had one patient who literally, her withdrawal symptoms was the hyperemesis cyclic, and literally the point that it impaired the ability to get on guideline-directed medical therapy. So I recognized it, we treated it, and boom. But that's the problem we run into. To Kelsey's point, I mean, we have patients that really do take it. She was taking it for PTSD. And everyone's like, well, we can just put her on an SSRI or blah, blah, blah. And I'm like, well, apparently she's tried that and therefore, but gone through it. But the hospital is absolutely nope, nope, nope. So it's still hard. And it can lead to bad outcomes because of the legality issues with that.
I would agree with that. So we are seeing that as well in the world of neurology and psychiatry. So that is a That's a true problem and it's real and you got to look for it and you need to really assess for it on an ongoing basis.
I mean, honestly, so I mean, we're about to publish this analysis, but 1 in 3 of my heart failure patients on this in the entire University of Colorado health system test positive in their urine for cannabis. 1 in 3 patients with heart failure realize that that could impair their ability to get advanced therapies, i.e. a heart transplant, as well as like a left ventricular assist device, but particularly transplant. But when I saw those, I thought I had to do a double take. And those were just the ones that were positive based upon urine tox screen, which we have to do for advanced therapy evaluation. So you have to be non-judgmental. You have to be transparent or you're not. Because remember, patients are going to do what they want to do. So.
Yeah, very, very true. And I think, the legality has really made it a lot easier for patients to talk to practitioners about it. Huge shift.
It's a generational thing, I think, too. I think younger trained providers are a lot more open, I would say, than my 85-year-old cardiologist. Yeah.
So I think we've touched on a lot of the risks of long-term use, including related to the heart and psychiatric conditions. But something that truly comes up with any recreational substance is the habitual formation tendencies. Even coffee, if you don't drink it, but you do drink it every day, and then you skip a day, you're gonna have a pretty bad headache. And that's kind of what addiction is. And in some cases, cannabis has much more of a withdrawal symptomology. So could you talk a little bit more about what cannabis use disorder is and what that entails and the risks of withdrawing from cannabis?
So, again, this is where it goes back to all providers really should be screening their patients. And we have tools for this, but it's about 30% of people, I think it's over the age of 30, who use cannabis are at risk for cannabis use disorder. In particularly, males are at a higher risk as well. So those are things we need to be aware of. But it's in the DSM-5. We can look it up. But pretty much it's like chronic use, high doses, and it's really patients who are missing events in their life because they're using cannabis, or they want to stop and they can't stop. So there's a list of categories that qualify them for a higher risk of cannabis use disorder. So as providers, it's really important once the patient tells us to keep doing that screening and quantifying how much cannabis they are using so we can make sure to track it and see if we notice any trends, so we can catch it really quickly and talk to our patients about it really quickly.
And I think some of the withdrawal symptoms you've already talked a lot about, but it's essentially like withdrawing from any psychotropic medication. So you can see the itching, you can see the sweating.
And the bad nightmares.
Yes, bad nightmares. And it's really unpleasant and can be very unsafe.
Yeah, we want to educate our patients too, if they do have to get off of it, to, just like any other medication, to do it very slowly, to have providers help you titrate patients off of it. Withdrawal symptoms typically last 2 weeks, but for chronic users, I've seen it last much longer than 2 weeks. So again, just educating our patients appropriately.
I wonder if you could chime in, Dr. Sisti, about this and how it really ties into the psychiatric context that you specialize in.
Yeah, sure. I mean, I think this is a big issue in psychedelics as well, actually, both cannabis and psychedelics, where folks who have maybe bipolar disorder or a psychosis spectrum disorder really need to think carefully about recreational use, and their physicians really need to dissuade them, I think, from trying these drugs at least or until there's better evidence that they might be safe for them. Again, this is an area where there needs to be much more research, but the signals that we're seeing right now indicate, I think, an ethical obligation to try to steer your patients clear of these medicines if they have certain psychiatric predispositions, histories, or family sort of histories. Otherwise, I don't think the risk benefit analysis is, too favorable. It might be the case you might say, okay, so for someone with like acute nerve pain in the back, maybe for a little while cannabis is okay till surgery or something. But yeah, long-term use, I would think, is probably a hard sell when you add up the risks and benefits for somebody who maybe has a history of psychosis, for example. That seems really problematic. So I think, yeah, I mean, the psychiatric comorbidities, I think, will need to be understood and need to be much more, sort of up front in terms of how patients are counseled. Dispensaries also might want to think about some kind of educational intervention there too. Maybe having a handout or something, some kind of warning. I don't know. Around the sort of signals around psychiatric conditions. On the other hand, I think cannabis can actually help people with certain psychiatric conditions that often co-occur with some, psychotic syndromes, like anxiety, for example, or depression, even PTSD. So, it's a complicated question, but at the bottom, I think the evidence suggests that people with these conditions should really avoid cannabis and psychedelics.
Thank you for that. And now I'd like to open up the questioning for the audience. It looks like we have a few in the chat, but if anyone in person has a question, I believe you can press down on the mic button in front of you. Have questions in the chat?
Thank you so much. I am a dentist, oral pathologist, and this is a really area of concern because I just think that we see, and I'm surprised about this, that a good third, now you just justified why I think I'm seeing our patients openly admit it. They almost like a badge of courage, like, yes, I do it. And yet we don't know how to counsel them because we have, we think it's causing periodontal disease. We think it's increasing their risk for oropharyngeal carcinoma. We think this increases their risk for candidiasis, but we know what tobacco use does, right? And so we're kind of transferring that information over to what we call marijuana most of the time in our clinics. And I just am really excited about having these toolkits that are interprofessional that we could actually use in our clinics in order to have a little bit more data and to be able to speak a little bit more confidently about what some of these side effects are. I don't think my patients are going into psychosis, but they definitely, have anxiety and they definitely have advancing periodontitis, all right? And so that immune suppression component is also really very important in our population. So it's this really interprofessional education that we need for ourselves so we can be better also for our patients.
Now I'm very interested. So what are you seeing in your practice? Are you seeing an increased risk for periodontal disease in the individuals? I would think it's a little bit more minimal with the orals, but with the vaping and all the crap that goes into that, and then the secondhand generation,
Yes, no, absolutely. Again, it's hard to tease out, but we feel like we are seeing those increase in periodontal disease. We're seeing increase in caries, right? Because again, they're going to eat on a regular basis. And so root caries is a real common problem too. And then we it causes sometimes kind of a dry mouth too, right? So that increases all of the oral health conditions. And yet we just are using data that isn't very sophisticated. And I should say more emphasis is going on in this area because it definitely causes a dysbiosis. And we know that people are vaping too. And then we have that dysbiosis with vaping along with using it. So it's hard to kind of tease out all of these different factors. But I just don't feel very responsible saying, thank you for letting me know, because I don't know where else to go with it.
We're done. We're going to talk to you because I'm honestly, that is one aspect that has never, in the literature, I've seen dental health. It is.
I didn't even think about it.
Wonderful. This is great. Okay. Yes. Great.
Incredible. Yeah.
All right, I think we have questions from the chat coming up, unless anyone else in person had one. There. Go ahead.
Oftentimes when we see medical cannabis, we see really low dose or low potency. A lot of patients are using higher concentrations. Is there any potential for studies? Is there any evidence that's available? And how are those harms potentially greater if they are greater?
Anastasia, great question. And you're so correct about the dosing issue. And as you know, we can't really study that legitimately on campus. So we can't give a product that's a very high concentration like dabs or shatter or any of those things, because we're really constrained to giving products that are running through NIDA. So we've had the supply from Mississippi, which we've had great luck in our clinical trials using those particular products, but they're medium, strength or a lower strength. So we do have a current trial going on now that is a pure THC, but it's not getting to those super high concentrations. So that's so studying it in at a major university is very difficult. So a lot of times we're relying on observational trials or trials that were at least not giving the product on campus. So there are some outlying clinical trials that are looking at that, but they're not giving the product on campus.
Yeah, and when you have a patient, if they're like, oh, I inhale twice a day, no big deal. But if they're inhaling, I think the average in Colorado right now is like the flower is 27% THC. I had a patient using 80% vaping. That math on how much THC that patient's actually getting varies greatly. And so again, we really need to be asking those questions and educating our patients, because that person who was using 80% was like, is that a high dose? And I was like, and so again, we need to be asking our patients the detailed questions so we can provide better education.
And one of the to that point, observationally, I am observing, it's just like with drugs, there's usually sometimes a threshold via which a dose threshold where you'll get a drug-drug interaction, and I'm observing that right now with our patients. The other is there was an elegant study published in the Journal of the American Heart Association, which also looked at length of time in individuals. One of the problems with all cannabis research is that it's confounded by smoking. So, which is, yeah. And so in this particular study, these were individuals who had never touched a cigarette. But the key is that the longer that they used it, okay, for greater than 5 days, you continue to have an incremental increase in your risk for atherosclerotic cardiovascular disease, so ASCVD, which means i.e. myocardial infarction. So I do believe that we're going to find that, but we just don't have, it's all observational.
Thanks. Okay, this is a question from online. This is from a neurologist here on campus, Dr. Perry. And she's asking, how should we think about the balance between pursuing FDA approval for specific products and indications versus allowing broader use through decriminalization / legalization? And what are the ethical trade-offs?
Yeah, I guess a couple things come to mind. I mean, obviously, you need the larger clinical trials if you're going for an FDA approved indication. And that's hard, right? And it's a lot of money, and who's going to pay for that? So that's one major, huge issue. The other thing that I think is we should be publishing the results that we have and not keeping a lot of the data in-house. So, and then identifying places where patients can actually obtain cannabis products that you know are reliable places. So I think that opens up a lot. Well, if you know the places, so it's and I think that's where it comes down to teamwork and sharing our knowledge that we have with each other.
Yeah, and I mean, we're trying to treat this like a drug, like we're trying to, the FDA, and this is why we're not really getting anywhere because the plant is, like we talked about, lots of different compounds. And so we're going to have to treat cannabis very differently when we go about, FDA trials, and we're having all these holdups because we're, again, trying to treat it like a normal drug, which we need to start bending our rules so we're able to open access, but also be studying it appropriately at the same time. And so I think until we start, we're seeing that slowly with some of the regulation going on, but it'll probably be years before we're able to study it like the way we want to.
Absolutely. And the genie's out of the bottle. We ain't going back. I mean, I hate to say that. That's just basically what it is. And I think how I think will end up happening, it will end up being like beta prostate or all those supplements that you see advertised where, again, it'll say this has not been studied for diagnosing or relieving blah, 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 which I think is, again, just, I think it needs to be studied, but I think that's probably where it is, but the genie's out. I mean, the horse left the barn.
Yeah.
I don't think you can go back. It's just, ugh.
Yeah. I agree with that. I think it's probably unlikely that there will be any companies that stand up a big clinical trial. But also I think there's ways we can gather data through naturalistic type experiments and studies and potential like data registries where consumers and clinicians can enter adverse events and just, show that, what strain it was, put all the details in, and then build a database that could eventually be used to kind of unpack some of these questions. But yeah, I'm not feeling very optimistic that there's going to be any like phase 3 clinical trials by GlaxoSmithKline on cannabis or something.
Even though I will say this, there is a phase 3 trial with CBD, in which they're looking for it in terms of reversing cardiac stunned ischemia. And because I thought about jumping ship, be that MSL, that sounds like fun. No, I'm just kidding. But I do know that's the only one that I'm aware of, and they're using the natural plant anyway. So who knows? But the other thing I want to comment on, cannabis isn't cheap. If you go to any dispensary, on average, if you want to get a cream, it's $60. You want to get a vape, and it's the higher end, it's $60. I mean, these things are not cheap. So just to let you know, and their insurance ain't going to cover it. So.
Very true.
Yeah, it's expensive.
Another question from online?
Yeah, another question. So this one's interesting. When we were planning this discussion, we went back and forth between the focus, and we decided to focus on medical cannabis versus recreational. But this question is kind of tying those two things together. This participant is wondering if the panelists, including Dr. Sisti, could comment on their feelings about the public health implications of recreational legalization of marijuana.
So, I mean, I think the public health implications are similar to other kinds of, drugs out there that people use for recreation, for socializing, et cetera. I think from my perspective, the risks are probably much lower than alcohol, to be honest. but that's just my take. I think there's an interesting question around around cannabis use and driving, and whether it's safe to drive and smoke cannabis or use cannabis. I can tell you that in Philadelphia, I get on the main highway and I smell cannabis immediately, and it's very disconcerting. So I think the recreational scene has, even though it's only medical in Pennsylvania, everybody's got people can get a car pretty easily here, or go to Jersey and across the bridge from Philly. And that has created some interesting public health dilemmas related to driving in my view, and safety in that regard. I would also say that the notion that cannabis is potentially a medicine, kind of intersects or interacts with the idea of recreational use, because people are thinking maybe it's healthy for me to use this recreationally, and it maybe it may not be. So I think those two things interact in that way as well.
From a public health standpoint, one of the things that worries me is we're going to see a repeat of what we found with cigarette smoking. For example, I mean, I am old enough to remember when I had attendings in the CTICU in South Carolina smoke cigs while we were rounding. I mean, that's how acceptable that was. And yet we've had this robust data to show the increased risk for stroke and this and the other, but we've been doing this since the 50s and it still hasn't curtailed. And so I think that's what worries me the most, is that we may have a whole generation of this that's going to impact that we may not see until they're 40. The other thing too, remember your frontal lobe doesn't develop to what? You're 26. And that's why I tell people, don't do it.
Lucky.
Yes, if you're lucky. Yes.
Yeah,
Don't
yeah.
do it.
Well, thank you all for that. We're running out of time here, so I'd like to give each speaker a moment to say any closing statements, big takeaways that we can all leave here with to really impact the health of our patients.
And being non-judgmental. And the problem with most providers is we talk too much. We need to listen.
I echo that with listening, and obviously being open-minded, and screen for drug interactions.
Echoing the same thing. And I think we need to do a better job of, I'm just going to let the pharmacist talk about it. We need it to be on the intake form and not under like recreational drugs. It needs to be next to alcohol, nicotine, medications you use. We need to have the MA, the nurse, to be asking, because maybe by the third time they see me, they'll be comfortable talking to me about their cannabis use. But if it's, only the pharmacist talks about their cannabis use, then a lot of times they get to me and they're like, no one's, mentioned it before. Am I allowed to talk about it? So we need to do a better job with all of our healthcare providers, normalizing it, and having everyone ask about it. Because again, it's scary for patients. For a long time they couldn't, and now we need them to, because we know a lot more.
And remind, as I said, as a healthcare professional, I remind people I am not the police. I am here for your health. So, but honesty is the best policy.
Thank you. And Dr. Sisti?
Yeah, I would echo everything that was just said, and just, add that I do think so. I'm a big fan of cannabis. I think it's a very helpful drug, but we really need to have clearer warnings about the big ticket risks, and clinicians need to be educated. There should be courses in medical school and nursing school, in every clinical school, about cannabis use and what needs to be done to safely use it with patients.
Thank you for that. And thank you for the speakers here. I feel like I've learned a lot, and I hope everyone in the audience has too. We'll be sending out a survey so you can give us feedback. Tell us if you didn't learn anything, and next time we'll try harder. And thank you all for coming. Please grab some pizza on the way out.
Thanks so much.